Hi, good afternoon, everyone, and welcome to our call today on Cardiac Highlights Huddle, where we are going to share some success stories and work through some of the improvement barriers that you might be facing. My name is Rebecca Bally, and I'm a Facilitation and Improvement Specialist with Oregon Healthcare Quality Corporation, which has been contracted by HealthInsight Oregon to coordinate and facilitate these Learning in Action Network webinars. My role today will be simply to moderate, and I will turn things over shortly to our fantastic presenters. But first, just an update on some of the technology. We want to be checking in with you regularly during this call. And so one of the ways you can provide feedback is to submit your questions into the question pane at any time. We will also have several polls that you can respond to, and we would love your feedback through those. We have time set aside to address your questions throughout the call, and we welcome you to submit them at any time, though, so don't feel like you have to wait until the end. If you have any technical issues with the webinar at any point, please feel free to type that into the question pane, and either myself or my colleague, Marissa Sweeney, will help troubleshoot that for you. And lastly, we do ask you to please complete the post-webinar survey to help us in our improvement journey so that we can make sure these webinars and calls are as valuable as possible for you. Also, before we get started, a brief introduction to HealthInsight. HealthInsight is the Quality Innovation Network Quality Improvement Organization, or QIO, serving Nevada, New Mexico, Utah, and Oregon. There are 14 other QIOs that bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. QIO work is grounded in principles aligning with the goals of the Centers for Medicare and Medicaid Services, or CMS, quality strategy, which is to eliminate disparities, strengthen infrastructure and data systems, enable innovation, and foster learning organizations such as this. Along with the 13 other regional QIOs, HealthInsight is leading healthcare quality improvement initiatives, including the Million Hearts Initiative for the Medicare program for a 5-year period from 2014 to 2019, as guided by CMS. And this call, as I've said, is part of that Learning in Action Network LAN effort under the CMS project on cardiac health. When you registered, you were asked to submit a question or something that you really wanted to take away from this call. And several of you said that you would like a better introduction or overview, rather, to Million Hearts. And so I found this infographic on the Million Hearts website, which is a great resource for you at millionhearts.hhs.gov. And basically what we're working on is what the campaign is working on is to improve care based on these 4 measures, the ABCs. So A, aspirin use when appropriate, B, blood pressure control, C, cholesterol management, and S, the smoking cessation treatment, so screening and treatment. And you can read more about some of those target goals there. I do encourage you to look through the website to find additional resources and learn more about the initiative and what's happening in other states. But we are going to practice our first feedback poll. So let's see how this goes. Okay. So which of the ABCs would your practice like to focus on in the next 6 months? And go ahead and submit. There you go. Okay, we have just a couple more people to submit, and then I will close it, and then we can see how people have responded. Perfect. Okay. I'm going to close the poll and share the results with you here. So as you can see, or hopefully you can see, that majority of you would like to focus on blood pressure control, and then the next smoking cessation and treatment, and just a couple of you on appropriate aspirin use. So interesting that none of you are working on cholesterol management, but okay. Thank you for practicing that polling with us. We're going to use it a couple more times throughout the presentation. Okay. So here are our learning objectives for the call today. Want to discover some successful strategies to easily be replicated in your practices and with your teams. Identify some tactics that can be adopted and adapted. And then identify and share actionable resources from the project, from other project participants, so from each other, and from the HealthInsight project teams also on the call today. Here's a quick overview of our agenda. And finally, I would like to introduce our wonderful presenters today. First, we have Jennifer Elliott with a background in clinical laboratory science. Jennifer Elliott has been the quality coordinator at Canyon View Medical Group for the past 5 years. During that time, Canyon View has received awards and recognition for diabetes care, asthma care, blood pressure control, and patient satisfaction. In addition, Canyon View is recognized by NCQA as a patient-centered medical home. We also have on the call with us today Roseanne Hyman, an RN from St. Charles Home Health. Roseanne has over 30 years experience as a registered nurse, 20 years as a certified rehabilitation nurse, and 9 years as the quality improvement coordinator for St. Charles Home Health. She is a home care clinical oasis specialist and a member of the Oregon Association for Home Care's Regulatory and Legislative Affairs Committee. So welcome to you both. And without further ado, I'm going to turn things over into the hands of our capable presenters. So Jennifer, take it away.
Okay, thank you, Rebecca. HealthInsight asked me to share our story about our competition that we had this last winter. It was with Optum Care. I don't know if anybody out there works with Optum Care, but do I have control of my slides now, Rebecca?
Yes, you should.
Okay. Oh, there we go. Okay. So Optum Care hosted a blood pressure challenge, and it started on November 1st and ended on December 31st of 2015. 19 teams consisting of up to 10 medical assistants per team competed in this challenge, and 2 of the 19 teams were from Canyon View Medical Group. Each team had to submit documentation of notes from 100 Optum Care patients that had an appointment during the challenge date. And the goal of the challenge was to reinforce the policy of documenting any retakes in the patient's electronic chart. Teams were scored. They got 3 points if the patient's documented blood pressure was in the normal range, and if it wasn't in the normal range, but the MA retook the patient's blood pressure after letting them rest for a few minutes, 1 point was given for each documented retake for up to 3 retakes. Canyon View already had a process for documenting and retaking blood pressures in place, but the challenge helped to reinforce that process. If a blood pressure wasn't in the normal range, the MA would let the patient sit for a few minutes and then retake it. And after 2 retakes, if it still wasn't in range, the MA would add elevated blood pressure to the visit. And then the physician would be able to address that visit. If the MA got busy, he or she would make the time to retake and document the blood pressure, because they knew they were going to get points if they did that. And the team from our Spanish Fork office were the grand prize winners. This is a picture of our amazing group of MAs who won the challenge. Each participant, so all 10 of them, was awarded an iPad mini from Optum Care, and as well as a plaque to display at the clinic. So in addition to reinforcing our existing policy of doing retakes and documenting blood pressures, the challenge helped build a culture of teamwork as well. So we're always talking about working as a care team, and during the challenge, everyone pulled together as a team to make sure that they were doing their part. Ann Herbert, one of our MAs, commented that she felt the challenge helped patients get a better understanding of their own health, because whenever they did do a retake, the MA would communicate to the patient what they were doing and why they were doing that. So it's always a good thing when patients can become more aware and involved in their own health care. So that's pretty much everything about our competition.
Great, thank you so much, Jennifer. We did have a couple of questions, and just want to remind people to submit your questions here. But while you're thinking of other things to ask, we're going to do another poll and just ask you how you feel you might be able to use this success story in your own practice. So we'll put that poll up, and while you're answering that, Jennifer, somebody asked that you said you had existing processes for documenting and retaking blood pressure. What was the process like for developing that process initially? I know this specific project was about reinforcing that, but how did you develop that process in the first place?
Well, it kind of evolved through our quality team. We knew that that was something that we wanted to make sure that our patients were getting the best care possible, and that we were controlling their blood pressures in the best way possible. So we just developed that through the care team. We just put together the evidence-based process showing that if the patient weren't in range, that their blood pressure would be retaken after they had a minute to rest or a few minutes to rest. And then, also doing that once again throughout the process before actually making an HPI of elevated blood pressure for that visit.
Okay, great, thank you. And then some folks are submitting or responding to the poll question. We haven't launched it, or we haven't shared it quite yet, but there are some people who said they'd like additional information. So I'd be curious at what additional information you would like. So please type that into the question pane. We can make sure that we cover those pieces. So Jennifer, I know a lot of, on previous calls, folks have been really curious about what are the appropriate care guidelines and trying to figure out, how do you integrate that into your workflow. And so you were talking about that a little bit, but wondering if you could speak a little bit more to the letting patients rest before retaking the blood pressure and where that comes from.
Okay. Well, we get a lot of our evidence-based guidelines from government websites mainly, or like the American Academy for Family Practice, things that are proven and show to be, the best line or the best evidence of healthcare. And so you can go to those websites and find that information. But we do like to let, if they've just come in, they've been talking, or they've just walked back from the waiting room, sometimes that alone can elevate their blood pressure. So giving them a chance just to rest for a minute can help to bring their blood pressure back into normal range. And also, I'm sure everybody's heard of the white coat syndrome, where just being in the doctor's office can cause your blood pressure to be elevated. So there's just things like that, which make it a good reason to let the patient sit and rest for a few minutes, or as much time as you can give them realistically, and still keep that appointment within the 10 or 15 minutes that you have to allow for that appointment.
Yeah, great point, Jennifer. Really important, and I know I get nervous when I go to the doctor sometimes. Another question came in about the challenge specifically and where the funds came from to give out the iPad or the iPad minis, and so maybe talk a little bit about that, and then maybe we can think through what some other practices might do if they don't have that same source of funding.
Okay. Yeah, like I said, this was hosted by Optum Care, so they actually invited us if we would like to be participants of this challenge. And as soon as I heard about the challenge, I thought this is a great opportunity to really highlight our great team of MAs, because sometimes they get overlooked, and they're the ones that need to be the heroes in the story because they're on the front line. So I appreciated that Optum Care came up with this way to give them a challenge, and where they would be able to earn a significant prize. A lot of them were very excited to have a chance to earn an iPad. That was, that was lucky for us that they did that and that we were able to take advantage of that. But I know if you don't have a group that is sponsoring a competition like that, you could just do it internally, and if you didn't have the budget to do a bigger prize, just even gift cards or I don't know, some other type of award that would be meaningful to your MAs. That answers the question.
I think it absolutely does, Jennifer. Thank you for clarifying that for folks. And I want to bring the attention back. I love that you pulled out the patient experience piece and how your MAs were commenting that patients really appreciate being told what's happening and why they're resting, and just some of that education piece and helping to better understand what's going on with their health. So I think that that's such an important thing to keep in mind as we go through.
Right. That's one of our goals as well, is to keep our patients informed and get them proactive in their own health care.
Absolutely. And I think folks have submitted their questions. We are going to share the poll results, and it's actually really great, Jennifer. So 30% of folks said that they can replicate this program, and so that's really exciting, is that they're ready to do it and going to help reinforce their process. So maybe we could put you guys in touch about that. And then 40% said they could use elements of it, and so maybe that's some part of that funding piece perhaps. And then again, the other folks who weren't sure where to begin or would like some additional information, please, as you're thinking more about this throughout the other presentation, chat in your question. And while we've got Jennifer here on the line with her great experience and expertise, now's the time. If you have a question, I'm sure other people also have a question. So, okay, thank you so much, Jennifer. I know Jennifer is going to stay on the line, and we are going to transition over to our next presentation. There we go. I had a quick little technical glitch. But I would like to turn things over now to Roseanne to share their success story at St. Charles Home Health Services.
Thank you, Jennifer. Good afternoon, everybody. So our challenge, as most of you know that work in home health, last year CMS initiated the 5-star ratings for home health agencies, and we started out with a first report of having 3 stars. So our goal was to increase our star ratings by half stars for the following outcomes: timely initiation of care, the flu vaccine, and the one I really want to concentrate on the most today is the drug education on all medications, improvement in bed transferring, and improvement in pain interfering with activity. So we started by focusing on 3 process measures: the timely initiation of care, the drug education on all medications, and the flu vaccine, because we figured that these 3 are pretty easy to make changes in. With the medication question, one of our assessment questions on the OASIS has to do with patients' ability to manage their oral medications correctly. So they must be able to take all of their oral medications reliably and safely, including the correct dosage at the appropriate times every time. So we did some education with our staff because all of our staff are doing that ongoing medication reconciliation and education with all of our patients at each home visit. But they weren't giving themselves credit for that on the OASIS. They were at the end of care, they were marking the OASIS question that they hadn't done the drug education. So we did a lot of education on that with our staff. We actually improved our star ratings from 1 star to 3 stars. So our overall star ratings went up from 3 to 3.5 stars just in the first 120 days of 2016 by doing education with all of our clinicians. And then our patient satisfaction surveys, we were not getting very good scores with our medication-related questions. But again, by doing staff education, we were able to really get all of our medication-related questions on our patient satisfaction survey are currently above the national average. So we've done a lot of, like I said, staff education around OASIS accuracy, especially at start of care. Clinicians were marking the patients too high, and really at the start of care, patients do not, most of the time, take all of their medications correctly. They need that ongoing education, especially if they just come out of the hospital. So we did a lot of focus on OASIS accuracy, and we have shown that improvement. So out of the 9 quality outcomes on the star ratings, we had significant improvement in 6 out of the 9 quality measures. Any questions for me?
Thank you so much, Roseanne. Some folks were asking questions about the specific education method and what that looks like. Are you using a specific model when you're talking to patients about their medications? Do you use any sort of health coaching or the teach-back method?
Yes, we do the teach-back method. We also came up with standardized medication list that the clinicians, when they go out to the homes, are helping the patients fill out so they can have that list when they go to their doctor's appointments and making sure that they have that medication reconciliation.
Great, thank you. And you know, we wanted to pull this piece out specifically because sometimes when you're when folks are trying, or when you're trying to help patients manage their blood pressure, they might be on multiple medications, they might have other things going on, diabetes and that sort of thing. So, and I wonder if you do you have, somebody asked, do you have a specific story? And this might be putting you on the spot, but somebody asked if there was a specific story that that you could recall of somebody who's been helped by this change, a patient.
Well, I don't have a specific story, but I think on our patient satisfaction surveys, on the questions related to medications, like a few years ago, we were scoring below the national average. Some of our patients were scoring like 50%. We're now in the 90 percentile for most of the medication questions. So I think that in itself speaks to the work that we've done. The patients are satisfied. They're answering that the clinicians have taught them about the side effects of their medications, what time to take their medications. I'm trying to think of all the questions on the satisfaction survey. the purpose for taking their medications, did somebody ask to see the medication? So on all of those HHCAPS medication-related questions, we have shown a significant increase in our satisfaction scores.
That's amazing, Roseanne. I just want to congratulate you and your team on that. I mean, that's really impressive. We just opened up the poll again for folks to submit. You know, can you use this awesome story in the care that you're providing, and how can you pull it back? And looks like we're pretty evenly split right now. So keep submitting your questions. If you're not quite sure where to begin, or you'd like some additional information, keep submitting the questions there. Roseanne, I know you had said that you started focusing on the 3 process measures that we mentioned before: the timely initiation of care, drug education on all medications, influenza vaccine received in season. Can you say a little bit more again about why you picked those ones, and if that might be some, and how other people might get started if they're looking to improve? What was your process for choosing those process measures?
Well, we looked at, all of our patients for Medicare regulations are supposed to be admitted within 48 hours from the time we get the referral. And again, we were doing fairly well with this, but it was, again, the education with the staff on the OASIS question, making sure that the date they put on their assessment matched the actual dates that we got the referral. A lot of times they were documenting it at a later date, so they didn't have that accurate. So we went from, on the timely initiation of care, we originally were at 2.5 stars. We brought that up to 3 stars for that quality measure. Again, the drug education on all medications, it's a requirement that our clinicians are talking to the patients about their medications at each home visit. So we figured that they're doing it, they're just needing to document it appropriately. And with the drug education, like I said, we went from 1 to 3 stars. The flu vaccine, we went from 3.5 to 4.5. So it's like I think we chose those because they are pretty easy to make a change in. Some of the other ones we don't have as much control over, although we are starting to focus on the ambulation and improvement in pain. But those 3, just by doing education, starting with those 3, it was easy to make a significant improvement in our star rating.
That's great. I think a good lesson for folks that might be feeling a little bit overwhelmed about all the possible things they could tackle to improve, and it's just starting with something pretty simple or relatively something that make a huge impact by doing just a little bit. I think that's a great lesson for people, that it just takes a small start at first and they don't have to be so overwhelmed by all the options.
Absolutely.
Yes. There was one other question that came in about the education, specifically about entering into OASIS and what that looks like, and I think maybe some context too that I'll just insert here. But I know some folks that I've talked to have feel like they're doing really great care. They're providing what the recommended evidence-based care is, but they're not getting recognized for it. And sometimes part of that is it's not being entered in the appropriate way. So what did your process look like for training folks about, or training folks on how to enter into OASIS properly?
We just currently did a mandatory 90-minute webinar that Cindy Kraft presented on OASIS accuracy and how to answer the questions accurate. Like if a patient is at high risk for falls on start of care, would you really want them to be independent? Because a lot of times our clinicians were marking that the patient was independent at start of care. Well, if they're independent, then they really don't need home health. So just, again, educating staff in the accurate way to answer OASIS, thinking about it as a data collection tool rather than from a clinical standpoint. Some of the questions are more clinically based, but a lot of them, it's really you have to think outside the box and make sure that you're accurately capturing what you're doing, because it takes the clinician maybe going in and setting up a MedMinder for a patient. You're doing that intervention, so you need to take credit for the interventions that you're providing. The patient wasn't independent when you first walked in there. Maybe by the time they're discharged, they will be because you've done your clinical intervention. So it was just kind of getting them to rethink how they're scoring on the OASIS.
Thank you. Yeah, I think that's really important for people to keep in mind is having a common language. We're all talking about the same definitions. This is what it means to be independent, and this is, and then also making sure you're capturing it correctly in whatever platform you're using. So, great, thank you. Last question. Somebody asked if there are handouts available, and I think this is maybe a general question. The slides will be posted online on the HealthInsight website following this webinar, following this call, along with a recording. And but I guess to Roseanne and Jennifer both, do you have any sort of handouts or resources that you've used in your process that folks can look at?
I do, so I can send you my email contact if people want more information or more detail. I can certainly email those out to people if they're interested.
Okay, great, thank you. Go ahead, Jennifer.
The same for me. If anybody's interested or wants more information or detail, I'm happy to provide my email address and provide them with any information I have. Okay, perfect. Thank you both. Maybe we'll just put it in the chat for folks to look at. But I think those are all the immediate questions we've gone through. Thank you so much, Roseanne, and for sharing that. And we, likewise with Jennifer, they'll both be on the line, and we're going to sort of transition into a broader open discussion about and then these are your project leads from each state with their emails as well, and a few of them are on the call today. But we wanted to spend a bulk of this time talking about some of the barriers that you are facing and have you be able to talk to your peers about ways to address some of these challenges. And then you've just heard two really great success stories from Jennifer and Roseanne, and maybe we can try and pull some of those elements in and some of that success into addressing these barriers that you've shared. So a few of these came up during registration. Folks were asking about follow-up tips for hypertensive patients, how to improve and demonstrate improvement in health for patients with or at risk for cardiac disease, and then more specifically about strategies and workflows. So what I'm going to do now is I'll start the discussion off with talking about maybe some strategies for follow-up tips for hypertensive patients. And each of the panelists who are on the line will let me know if they want to address this first. So we won't talk over each other, but I'd like to throw this question first to Rebecca Durham from Utah. Do you have any tips or things that you've heard from practices about how folks are following up with hypertensive patients?
A couple of practices that we work with have started instituting, and I think maybe if I'm understanding the question properly, have started off in hypertensive visits or blood pressure checks, basically, so they can come in and may take the blood pressure and not have to pay a copay or anything for that. So that's been one kind of follow-up thing that a lot of people have done. Some successful practices have really started using MAs at the top of their licensure so that they can be the ones to do some follow-up phone calls to patients, and the response is that patients are really receptive to that because they feel like they're getting some special attention, and so that has helped in compliance is, a word that gets thrown around, but patient compliance with making sure they're staying on top of things and reporting back to the MAs and the nurses about what's going on with them. So those are a couple of things that I've heard, and then people that are really getting good at running reports in their EHRs and running patient registries. That is extremely helpful, and that's challenging for a lot of people if they're not familiar with that or used to doing that. That's where your HealthInsight representatives and folks can definitely help practices with those sorts of things. But managing patient registries that way to find out who is in control, who is still, has a diagnosis of hypertension but not meeting their control rates, that's been really helpful to practices as well. So hopefully that answers that question a little bit.
Perfect. Thank you, Rebecca. I think those are some really great examples for folks. And I want to flag that we did do for these and webinars, we did do a webinar on population management in March that people might refer back to, and that's also on the HealthInsight website. We can put the link in just a second. That might be a good resource. But Jennifer, is your clinic or any of the clinics that you work with working on this specifically on follow-up tips or following up with hypertensive patients and trying to
yeah, this is an ongoing thing at our clinic, and actually we do all three of the things that Rebecca mentioned as far as our patients can come in and have their free blood pressure check at any time during our working hours, and as well as our data that we run internal reports, and our goal is to keep our patients who are managed around 78%, which is, I think, the national benchmark. And I know right now we're hovering right around 79%. So we do a lot with that, with running reports and watching that data. That was a meaningful use initiative as well. So that's how we got into doing that. But another thing that we do for our hypertensive patients is we try to educate them on the DASH diet. This is a diet that there's a lot of information out there about, and it's a diet that's healthy for people to follow, and because of the fact that there's a lot of information available, it can be fairly easy for them to get that information and follow that diet. So that's just one of the other things that we do is promote the DASH diet for our hypertensive patients.
Perfect. Those are all really great suggestions. Thank you, Jennifer. And that's a lot of work that you guys are doing around hypertension. Roseanne, are there anything specific to hypertension that your team is working on?
We participate in the HHQI cardiovascular data, so they have been educated on what to document in the patient's chart regarding hypertension, and if the patient does have high blood pressure, that they're on the appropriate medications.
Great, thank you. So we can include some of those links and resources, and I think that with the HHQI, I think that's just on their website. I can look for that and type that in the chat in just a second. Another question that came up a couple of times were various forms of looking at using data and how do you actually show improvement in the health of your patients if you're looking at folks who are pre or at risk for cardiac disease or who currently have risk for cardiac disease? How do you actually demonstrate any improvement with some of these efforts and projects that you might be rolling out? So again, I'd like to start with Rebecca Durham and ask, how have you seen teams using data to show this improvement?
Oh goodness, lots of ways. You know, if practices or home health agencies sign up to work on this initiative with HealthInsight, we're able to put together some data feedback reports based on the ABC's measures that get reported in the EHR. And so a lot of times we will use those data feedback reports to drive the conversation, and data definitely causes improvement, good or bad. And sometimes bad data is not necessarily a bad thing, because it can tell you a lot about what's going on, or at least gives you a place to start digging into what might be happening and looking for gaps in your process. So using those data feedback reports, or if people are savvy with their EHRs and are familiar with running reports that can get at these measures, that can be used for data-driven improvement as well. And trying to think off the top of my head here if there's any other instances, but really that's where we use a lot of that data and try to use that in our conversations with practices that we work with as facilitators here at HealthInsight.
Great, thank you. Just a reminder for folks to be in touch with your project lead if you have more questions about how maybe you can partner more or get data to help you on your improvement journey. And Roseanne, I'd like to throw this one to you as well, because you were clearly using data and use that as a starting point in looking at where you would like to improve. And I'm wondering more about how you communicated those results to your team and use that as how did you display the data? How often were you sharing the results and improvements? What did that look like?
We have quarterly discipline meetings and also quarterly all-staff meetings where the data is put up on the big screen for people to look at. And again, whether it be good or bad, we share that data, and we have a customer service improvement team that looks at the data as well. It includes a well-rounded group of clinicians, a physical therapist, occupational therapist, speech therapy, myself, and even an office person. We pull up the data when we meet on our monthly meetings, and again, look at what we can do, where we can focus, where to start our focus, and you have to look at the data constantly. It's a moving target, and you really want to get your clinicians comfortable looking at the data and know where they can make a difference.
Great, Vicki. I think that's a good model and a good reminder and lesson that you have to look at the data. I think people sometimes feel intimidated by the data, or they think that, you know, data is going to make them look bad in some way. And part of it might be that culture shift of, you know, yes, our results are not so hot right now, but that's why we're going to work on improving it. And it's not to play the blame game or to shame any one person over another, right? It's really just to look at how can we, as a team, provide better care for our patients. And so I think sometimes those are conversations that have to happen in the team when you first start using data. So I don't know if that's something that you have found, and Roseanne and Jennifer, do you have? I know you have some data that you work with. What does the process look like for your team? Do you share quarterly or monthly or?
Both. We have a quality team that meets every month, and we share data at that monthly meeting, and then we try and update the doctors quarterly on all the measures that we're working on. So that's how we do it in our office.
Perfect, thank you. There are a lot of different ways that data can be displayed too, and some of it's just trying to figure out the best charting, or is it really just the numbers that we're looking at, or sometimes you can get fun with data as well. There's one practice that I worked with who had they created this little racetrack image on in their, I think it was their Huddle area, and they were working towards, I don't even remember what they were working towards, but each team had a little car, and it would go around the racetrack in a circle to people would be racing to improve their results. And it's kind of fun because it also shows that this continuous process, you don't just come to the end and improve and then you're done. You keep working on it. And so there are a lot of fun things that you can do to work with data and actually demonstrate improvement to your team internally. But then also externally, I think getting credit for some of that work that you're doing goes back to even Roseanne's example about making sure that people are using the same common definitions and entering the data appropriately and accurately. And then also back to Jennifer's success story about, they had this process in place, and they did this incentive program and project just to reinforce that, to make sure that people were actually entering the data appropriately. So there's a lot of stuff, and it's an ongoing process for everyone. So there are resources out there. Please don't feel like you're alone.
And Rebecca, this is Rebecca in Utah. Just to add to that too, a lot of times in quality improvement work we talk both about outcomes measures get a lot of attention, right? So the blood pressure control rates, those sorts of things get a lot of attention. But the process measures are also important to keep track of when you are implementing a quality improvement project. So you may decide that the data you want to track is, how many times resources are given to patients and then track results or whatever. I'm just pulling that off the top of my head. But some of those different process improvement measures are good for the interim while you're sort of waiting for outcome data to come to you. So sometimes the process lost in the shuffle because there's a lot of focus on outcomes, but both are very important to keep track of.
That's a great point, Rebecca. Thank you for mentioning that. I think people do maybe sometimes get stuck, and part of it is looking back and what are the, like Roseanne's example, what are the three things that we can focus, what are the three processes that we can really impact to make a big difference on the outcomes for our patients. So great to bring that up. Looking through a couple of the questions. I think that some folks are asking about how do we adapt this to improve cardiac care at our within our team, and maybe this is a bigger discussion about you have the success that worked at one clinic or with one home health agency might not be the exact same thing that's going to work for another site, and so. I don't know, Rebecca, if you could speak to maybe how people can just pull pieces that work for them and how they might go about doing that.
Let's see. Well, I would say that it is important because each practice is going to be, each care setting is going to be unique, and the people in it are going to be just as unique. And so it's really important to self-assess your current process and be really honest. There's no blame, no shame in things that aren't going as you'd like them to go. So to me, that's an important thing, is to do kind of a self-assessment, whether it be workflow or your training standards or your documentation practices, and really get a good idea of where you are, and then decide pick just one thing. It doesn't have to be big. Just pick one thing that you want to look at and try to pick out and improve. Maybe something similar to what you've heard panelists speak about today, or you may come up with something entirely different that you identify as a gap in what you're doing that you want to give some attention to for a while. And I'll just give a little plug too at this point too that we have for those of you that were on the last webinar, we talked about the blood pressure website that HealthInsight has, but the web address for that is www.healthinsight.org/blood pressure, and on there you will find an assessment that is geared more toward physician offices, but things like positioning of patients to take an accurate blood pressure measurement can certainly be applied to any setting. So I would encourage you to look at that self-assessment that we have on there, on that website, and it will direct you to different resources if you identify some areas that might need some improvement. So that might be a good place to start.
Perfect. Thank you, Rebecca. And I did chat that website into the chat box, so everybody should be able to see it and click on it. And then I also included a link to the Million Hearts website, which has a ton of great resources on workflows, strategies, materials for patients even. And then as well, right above that is the website for the HHQI cardio work that Roseanne mentioned. And I also included the emails for Roseanne and Jennifer. But we didn't have any other questions come in, and so at this point I would just like to turn it over to each of the panelists individually to, if you have any final parting thoughts for your peers on how to go about improving care. That would be a great time. So, Jennifer, any last thoughts?
Well, I thought what Rebecca had to say really was spot on as far as every culture, every clinic, every medical setting is going to be a little bit different. And so you kind of have to think outside the box a little bit and figure out how your workflow works and what you can do to incorporate different strategies into your workflow. There are a lot of resources out there. If you just start, Googling things, and you want to be careful to find those evidence-based resources and good, reliable resources. But there are a lot of them available out there, and I think if you just start looking into that, thinking outside the box, and figuring how that can work into your workflow, your environment, your culture, the possibilities are endless as to how you can improve processes in your own settings.
Perfect. Yes, thank you so much, Jennifer. That culture is so important and sometimes feels intangible, but it's definitely an important key piece to any improvement effort. Roseanne, any final parting thoughts for your peers?
I would just say you need to get not just, like I'm the quality coordinator for my team, but you really need to get everybody bought into quality improvement. It's not just one person's job. It's not like a department. It's everyone's job to make sure that we are providing the best evidence-based quality care for our patients. So no matter if you're a nurse, if you're an MA, if you're a physical therapist, you all have a part to play in quality improvement.
Perfect. Thank you, Roseanne. And I think that, and Rebecca, unless you have anything else to say, and I saw that Carrie is on, but we were having some audio issues. But Rebecca, anything else?
I do not, unless anyone has any specific questions for me.
I don't think so. Not that I can see right now. And then I'm going to try and unmute Carrie, see if there's anything she would like to add right here at the end, and then we'll wrap up. Carrie, you're unmuted.
Hi, can you hear me?
Yep, we can hear you.
Oh, yay. Hi. Rebecca, nice job. I learned a lot from you guys. And thanks to everyone who chimed in with questions and voted in the polls. I was just thinking about anything I could provide, and one is just, again, to if you want to work on improving cardiac care, including any of the ABCS measures, make sure to reach out to your lead. I'm Carrie Beck. I'm the lead for Oregon. And if you, oh, there it is. So feel free to email me, and we can start the process to work on whatever is most important to you. Including, we talked a little bit about data, and we here at HealthInsight have access to what is called the PQRS data, which is where those ABCS measures, one of the places those are reported to. We only have access annually, but you all have access to that anytime you want. So that's a great place for us to look at where your baseline is, and we could start some kind of intervention and take a look at the data a month or 3 months later. So I hope that intrigues you, because it's great to see if you're having an impact right away. So anyways, thanks to everyone. I'll send it back to Becca.
Perfect. Thank you, Carrie. And just a quick reminder that the PQRS piece, I think, is for physician offices only, but home health agencies do have their own cardiac registry and other ways of tracking the wonderful work that they're doing. So with that, I actually really want to give a humongous thank you to the audience, to all of you for submitting your questions and participating in the polls, but also especially to our presenters. So Jennifer Elliott and Roseanne Hyman, thank you so much for being brave and sharing your success story. It's really, I think for many people, it's easy to get stuck in what you're doing, and feel like you're all alone in the world. So it's so important to have people who step out and say, look at what we're doing. It's, you can do it too. And so thank you so much, Jennifer and Roseanne. We really appreciate you sharing. And a final note for please complete the post-webinar survey. It's very short, just five or six questions, but that helps us know how we're doing and what we can do better for the future. So what other topics do you want us to cover, that sort of thing. And then a reminder that our next call will be a webinar, and it's about the nursing visit in physician offices primarily, but how do you use other care team members to provide really good quality care for people or for your patients. So that'll be on Tuesday, August 16th. And here are some additional references that we talked about: the slides and the reporting. And the slides will have all the active links. Those will all be posted on HealthInsight website in probably about a week. But with that, I will give you all back the rest of your afternoon. Thank you so much for joining us.
Thank you, everyone.